and water. Dr. Vianney, one of the country's most experienced gastroenterologists, leads the procedure.
We discover what is causing problems. Kati our patient here, tamira. So waliwo ekintu ekigenda mu maaso kyetamanyi. So tosobola kiraba nga tokoze. You can't do without looking inside there. That's where you breathe from the other white one. But for us, we are coming down where the swallowing is. As you see, there's a lot of saliva which will suck out. And that's where the kizimba is. As you see, there is a kizimba which has narrowed. There's a disease here like this. This one is the normal size, the normal. This is the normal. But as we go, that is abnormal. This one here. You have seen. So it is preventing him from swallowing food. That abnormal part. There's just small, it has become so small, there's just a small part to pass. So that is the issue. So you see it has blocked, even my camera scope here can't go beyond there. So the purpose is to now take off some sample to see whether cancer or not cancer. But now we know there's something blocking. How many centimeters? Like 30 centimeters, somewhere around here. Around here. Biopsy. So you can ask, how are we making him eat? There's another department which deals with these things. After we take off and confirm, we shall come back and put a stent and put something to make the place open. 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 Close. So these are the samples we are taking away to go and test. So how we do this, we keep pumping some air to open. There's air we pump from this machine to open the area so that we can see. And also, we suck out any bad things. So this blue thing is the one we call a biopsy forceps, the one which picks the biopsy. Open. Biopsy. Okay, close. Endoscopy is not the same as the theater. So it's not a sterile procedure. It is just a clean procedure. Things that should be clean but not sterile. That's why you see we put on only this, we put on this. It's a clean procedure. But we also have to protect ourselves, you see, because we are dealing with the mouth. Someone may cough something, so we put masks on. So most of the time we take 3 or 4 samples so that they don't miss anything. They shouldn't miss anything when we do. So this patient in particular, he has some swelling in the esophagus. In the local language, one of the local languages, it is called omumiro. Open. Close. So we are about to finish. Are they big enough? In the same time, we are making a report there. You see there? That's why we make a report. We just don't see, we also make a report and give it to the patient. Open. Open. So we are going to come out now because we have finished. In all this process, because of our anesthesia provider, the patient is not feeling pain. He's sleeping lightly. And you will see that in the after like 2 minutes or 5, he's going to wake up. So endoscopy came into play a long time before even Uganda, because people have diseases of the intestines, which you can't see. First of all, this is inside our body. And most diseases of the intestine come from inside the intestine, not from outside the intestine. So the intestine is like a tube. So most diseases are inside it, not outside it. So if there's any disease, it always starts from inside and then goes spreading outside that intestine. So endoscopy was developed to, one, to see what is problem. When a person says, I have a pain, is it a disease in the intestine? Two, if it is there, how far has it gone? How advanced it is? So first and foremost, endoscopy started with people who are saying ulcers. I have pain here. I have chicato, like dyspepsia. We call it dyspepsia. So people say, but what is going on? What is really inside there? If I have a wound here on the skin, everyone can see I have a wound. But if you have a wound in the stomach, what we call ulcers, how will we know that you have it? We shall see the pain, but we don't know. Because pain can be because of the ulcers, pain can be because of cancer. For example, like the patient you have just seen, most likely that is a what? A cancer. We don't know. So that's why endoscopy came in, and it's really a very important thing. So first and foremost, endoscopy is to diagnose, for diagnosis. But after diagnosis, what else? There are some diseases, when we find them, we also treat them. So also endoscopy is used for treatment. So those are the two main things: to diagnose whether you have the problem, or
To treat.
Doctor,
how painful is it?
Have you ever put your finger
Yes,
in
that
the
is.
mouth here? It's not painful, but it is terrible. You want to vomit. You are gagging.
Surely.
And remember, the endoscopy is almost the same size as this small finger. So to pass it there is not easy. So it's not painful, but it is discomforting. Not everyone will you can't pass, so we have to do other things. So there are other things we do to make sure that we can pass the scope.
Okay.
Because once you pass it, there's no pain. There's no pain, but the problem is just passing it there. Yes.
As we saw, do you have to do anesthesia on everybody, or is it?
Now, initially, endoscopy was started as an office procedure. Office procedure means the more you get out anesthesia out of the procedure, it becomes easier to do it. I can even put someone on the bed and do it. Like, it's an office procedure. So there is a balance. Even right now, there are two schools. There are some who say, let's put sedation. What we call that is sedation. They give you some drug to keep you calm, basically to prevent you from fighting the scope. Then there are others who say, no, we shall not make you, but let's just spray just here. You saw a spray. We spray here to remove that effect. Sometimes the spray doesn't work. You spray. In some people, it works so well that you don't need any other extra anesthesia. So you just spray, and the point it goes. Then he says, yeah, it's okay. But other people, you can even spray, and still you need to give him some drug to sedate. And that one goes into the other second question you were asking: can I drive back home? Basically, the driving or not driving back is determined by whether we gave you some sedation or not. If we just sprayed you in the throat without sedation, you can drive back, because those drugs are not in your system. But if we gave you those drugs, we at least have to rest for maybe 4 hours before you drive. So if you're in a hurry, you may need to come with someone else to drive you, because yes, you may be awake, but we are not sure whether you are really sober properly. So that is 4 hours from the time we give you this anesthesia. So anesthesia is, people are now debating, but I see from my experience with the Ugandans, they are better off with some anesthesia given, because they have now, because of the way that effect is there, it has become dangerous. They give people, don't go for endoscopy, you will die there because of that terrible experience. And then we miss the diseases which we need to see early.
Yes, doctor, now that it goes inside the intestines of an individual, are there conditions, what should I avoid eating before an endoscopy? Or I can eat, it still doesn't affect what you do?
No, endoscopy you have to fast, we call it fasting. It is a minimum of 8 hours. For one reason. You remember, we are putting the scope. You can gag, and these things can come and choke you. So we don't want a full stomach, because that will choke you. You may get into other problems. But two, we want to see the problem. Now when you go there and you find food, what are you going to see? Just imagine inside here there is food, there is porridge, there is milk, yet your aim was to go to look for a disease, then the whole place is full of food. So both of them. Basically, we have some people where the problem is that the exit of the stomach has blocked. So already there is food. Even if they fast for 12 hours, there is what? There is food. Sometimes we have to put in an NG tube, these tubes, and first drain the stomach. Because we have to see the problem. Yeah.
How long does the procedure take typically in terms of?
Yeah, it is about experience. It's about experience and also about disease. For example, if someone is beginning, it's like all trainings and all whatever. If you're an experienced hands, someone can, like even driving a car, someone, or a swimmer or whatever, like all things which need experience. So basically it can take 5 to 15 minutes. Remember, you don't have to rush. The reason why 5 minutes you may be rushing for what? Because remember, what took you there is to find what? A problem. So me, average, I feel like someone should take, and people should take more time coming back than going in. You know, you're going in faster because you want to pass this place quickly. So the patient doesn't what? Fight. Then after you're inside there where there's no problem, take your time, look around, see what is going on. Is there a problem? But all in all, 15 minutes for endoscopy is the maximum in experienced hands. But even 5 minutes is good enough.
Would I be right if I said that endoscopy is free from any complications after the procedure?
No. The biggest complication, as we said, is the anesthesia complication. So that's why we select our patients. The other complication is if the patient lied and said, I've not eaten, yet he has eaten. And then when you put a scope, things come and choke. We can lose you. Now, that is for diagnostic. Now, the other end complications now come from the intervention. Remember I told you that endoscopy can be used to treat. For example, you find that there is, like stenting. Remember I said that thing has narrowed. We have to put in a what? A stent to separate. So in that process of stenting, it may what? Cause bleeding. So but that bleeding is anticipated. So we always prepare the patients for those procedures. There's also what we call varices. You don't know them, I can't say them, but in the process of plugging them, they can burst and they bleed. So intervention you can have, but the most complications of anesthesia are basically endoscopy anesthesia related, not surgical, not. Averagely, these endoscopes outside they are for up. These endoscopes up, maybe what the Mulago is 300K. Basically, one thing about cost share, it brings in. Sorry to divert a little bit politically. There is a way the cost sharing of Mulago became the benchmark. You understand what I'm saying?
Yes, I get it.
The benchmark on which all the other private people now, they always tell you, we are this above Mulago. Like it becomes the benchmark. Why do I bring it in? I bring it in because when something is at zero, everyone can query, you know. But if now people know that there is a standard on which we bench our things, you can't go and I remember when people never knew that Mulago has this figure. People would change patients 1M outside there, 1.5. But now people are wise. If cost sharing 300, really, what is so special are you putting in this thing to blow the figure out of them? I think my call to the government is that, I'm so happy that government has gone into specialized, but you know that we now have a specialized sundries like vote in the Ministry of Health. I think it is there. I think we are even debate. So it was set there because of these expensive things to really bring them closer to the people. So I hope that maybe the call is not only to the government but to the regional referral directors. they should be interested in bringing this, because it is a push, it is a pull. Like, you have to show that you need. So the regional referral directors really are in position, and I think they have the votes to have these endoscopy systems in their hospitals. So they should really push the government, and also, if it is there, the government should really not refuse to have this service.
Just under 15 minutes later, the procedure concludes. The blockage identified, biopsies taken. The airway, once a mystery, now mapped with precision. Bakuyitani mama?
Nalikasara.
Nalikasara. Nalikasara nga tonajja wano wabadde owulira otya?
Mbadde mulwadde kale emimira ebbanga ddene nga simira sisobola kumira nga nywa bunywi kyokka. Kati nga nze ngula eddagala buli kaseera nemira naye nga nsigala era ndi mulwadde emimiro nga gizimba bwe giti.
Kati ekirowoozo ky'okujja eno bakuteekemu akuuma kakebere munda wakiggyeewa?
Abasawo gye babadde banjanjabira eyo ewa Kisobe bansindika eno Mulago. Kusooka tubadde nga tujjanjaba Tensorites naye nga maze ebbanga ndowooza mwaka nga mulamba n'ekitundu nga tujjanjaba naye nga teziwona. Mmira ddagala ne bankuba n'empiso naye nga tewali njawulo, sigala ndi mulwadde era. Naye ng'eno ebweru towulira nti ndi mulwadde, naye munda sisobola kumira kintu kyonna.
Bwe bakebedde bagambye basanze ekyabasawo?
Ekifaananyi ekyasooka kyaŋŋamba ngu tewali kyamaanyi kye balaba, kati ne bansindika wano.
Wano bakumaze okukebera?
Bamaze.
Watege
tebannampa results.
Tebannakuwa results. Naye ng'akantu olina essuubi nti nno ono kijja kutereera.
Mukama nga ye mubeezi.
Amiina. These voices echo through the hallways, echoes of trust in a system fighting against time, against limited funding, against forgotten corners of affliction.
In this unit, we handle all the endoscopy requests. Usually patients come in with requests from different doctors, from Mulago Hospital and from outside Mulago hospitals, and we book them for endoscopy procedures. So we tell them what they're supposed to do to prepare for the endoscopy procedure, and we give them an appointment on when they're supposed to come and do these endoscopy procedures. We have very many patients and we work from Monday to Friday, so we book our patients accordingly.
This is the original endoscopy department, born from Uganda's commitment to sovereign medical excellence. Entirely government-run, this unit predates newer partnerships. Here, legacy meets evolution.
Thank you for coming to the Mulago Endoscopy unit. This endoscopy unit is open from Monday to Friday. Endoscopy is a service we have been having for many years, I think since late 1990s, early 2000, I think. So I've been having it for some time. And we have really served so many people. Endoscopy per se in Mulago is a cost shared service. We cost share it because the machines to do it are very expensive. The maintenance of those machines is a lot. So the cost sharing helps to do, and there's also what we call specialized consumables. Like if you saw that thing which went to pick a biopsy, that's a specialized consumable. That alone is like 1 million, you know. So those make the operating costs. So that's why we cost share it. I know it's government, and I won't really put it so much because cost sharing helps to maintain the service, or else it can get into, and many people are not helped.
What you've seen is only half the story. Across the hallway, a newer unit hums with innovations, a result of a unique collaboration between Uganda and South Korea. Next week, we'll take you there into a space shaped by partnership, innovation, and diplomacy. But for now, we salute the hands, steady and unseen, that make healing possible at home.
UBC, inspiring Uganda.
Hub, giving you a deep and unique insight into agribusiness, services, ICT and innovation, industrialization and so much more. Entrepreneurs Hub, growing your small, medium and large business entity. With yours truly, Sandra Kahunde, right here on UBC, inspiring Uganda.
Did you know that our #1 value as a nation is to respect and protect the environment? With the current population increase of Uganda and industrialization, this has increased pressure on the natural resources, resulting into environmental degradation and global warming. Developing countries like Uganda could face 80% of the global climate change effects by the year 2030 if no action is taken. Join us here on UBC TV, Inspiring Uganda, on our Eco Plus program, where we bring you an in-depth analysis of issues that are disastrous to our environment. Every Wednesday at 7:30 p.m, only on your loved station, the National Broadcaster.
I'm Dr. Julia Nageri Kamala, a doctor in agriculture and rural transformation. You are most welcome, UBC, at Delight Lawyer Business, where we have a motto, a Dairy's model, we learn by doing. Principle number 5 of Mo 7 Economics says market integration. We have done it. And he has written for the last 4 years. And he has directed what we need is power, fix our roads, and do very additional. As simple as that. If we do that, Acholi region will never be the same, because we have a capacity of processing the mangoes, the citrus, the guavas, the macadamia,